Hi, everyone. My name's Jared Bartell. I'm a neurologist at the University of Utah and headache specialist. We're talking today about tension type headaches. So thanks for joining our headache school. We have two talks every month, and you can always find it on YouTube. So here we go. So I'll be kind of going through what are tension headaches, what causes these types of headaches, and then I'll be kind of going briefly through the rescue and prevention side of tension headaches, and going through medications, non-medications, and I'll probably gloss over some of the more detailed information, but you can read that at your own pace too. So the obligatory kind of gross slide here on what are tension headaches from this MedComic website that I like to show. So this kind of just illustrates what are tension type headaches, but I'll go in more in depth with all of these things. So typically tension headaches are on both sides of the head. It's more of like a band that can last for hours or days. It's not associated with other neurological symptoms like what you would see with migraine, usually treated with basic over-the-counter meds, but sometimes we can use other things, and it is the most common type of headache. So these used to be called a number of different things. So stress headaches, muscle contraction headaches, psychomyogenic headaches, psychogenic headaches. These all kind of belie what the original kind of thought was for these headaches. They're just all stress related. It's all psychological, but we know now that that's not the case, and I'll go through more of this in general in detail. It's defined by the frequency. So we characterize tension type headaches by either episodic headaches or chronic tension type headaches, and the TTH is tension type headaches, of course. So episodic, less than half of the month. We break that up into infrequent. So that's the most common type, where it's like not even once a month you get this kind of nondescript headache that bothers you, may not even be so severe. And then in the spectrum with frequent episodic tension type headache, where it's less than half the month, but at least once per month. So 1 to 14 days out of the month. Whereas with chronic, it's more than half the month. And this seems like kind of splitting hairs, but it is actually important as far as like what's the cause and how to treat them differently. So this is, again, the most common type of headache. We don't see it as often in like neurology clinics and headache clinics, often just because the most of these are kind of this infrequent episodic, where it's not even once per month. There was one study looking at tension headache patients. This one showed 24 to 37%, at least once a month. 10 to 25% of the patients had weekly headaches, and then 2 to 3% of the patients had chronic tension type headaches, so more than half the month. So this is just one study, but kind of illustrates the spread there, where it's the least likely to have the chronic tension type headaches, but among the patients that do, those are among the most severe, types of headaches sometimes, and just difficult to treat, which makes it harder. There is a strong, not as strong with migraine, but there is a male to female predominance. So, or meaning that there's more females than males who have tension type headaches. Although with migraine, it's more skewed to the female sex. The average age of onset is usually 25 to 30. That's a little bit older also than migraine, which is like in the teens to early 20s. Prevalence for tension type headache peaks around like the fourth decade, so like in your 30s, and then kind of the prevalence decreases with advancing age, but it can still be be seen later on, even up to 60s, 70s, 80s, but not always. It can subside before then also. So this is just I like this infographic. It's from Nature Reviews journal, and you can read through this on your own too. But basically, the mechanism or the pathophysiology of tension headaches, we think, differs by episodic versus chronic tension headaches. So we know that in episodic tension headaches, people have more trigger points. They have lower pain thresholds in general, and a lot of these nerves and muscles. They tend to have less neck mobility and just mobility with their shoulders, their neck in general. Often a forward head posture, which comes with the modern living of needing to work in offices and being in front of your computer all the time. As these problems get worse and worse, you develop this problem called cutaneous allodynia, which is a problem that you have when you normal sensations that wouldn't have normally caused pain are now causing pain. So just like light touch on the head is now causing like much worse pain than you'd expect, or pain at all when you wouldn't have expected pain. And that's a strong kind of mechanism in converting from episodic to chronic tension type headaches. We think it's more of like a peripheral kind of a cause, like in the muscles and the tissues in the head with episodic tension type headaches. With chronic tension headaches, this is more of a central sensitization process where you can have kind of dysfunction inside the brain with the pain structures being involved. This is also how chronic migraine develops. But we do also think that tension headaches have some of this as well. So again, tension headaches are just kind of mild headaches without migrainous features. It may look like a lot of other types of headaches, so it can look like migraine. There is actually a spectrum between tension and migraine, it's thought, and so you can actually have both. It can look like medication overuse headache, which we'll talk about. It can look like secondary headaches, meaning it's coming from a structural cause or some sort of other problem, metabolic cause in the body. And that's actually the most common presentation of a secondary headache is looking like tension headache. And so it's important for your clinician to rule out those other problems, especially kind of, headaches starting out of the blue later in life. When you didn't have this headache before, all of a sudden you're having this tension headache, and it may very well be tension headache. Again, it's the most common, but it could be other things masquerading as tension headaches. So we use these diagnostic criteria to kind of formally, characterize headaches. And I've gone through these before with other types of headaches in other headache school talks. But for tension headaches, these are the criteria for infrequent episodic, so less than 1 day a month. But you still need to have at least 10 episodes, and then occurring at various frequencies, depending on how we're eventually going to characterize this to chronic or episodic tension headaches. They should last for 30 minutes up to 7 days, but it can last longer. And this is interesting because with migraine, it usually starts at like 4 hours, like it is 4 to 72 hours is where we draw the line. So tension headaches can be much shorter lasting. It tends to be on both sides of the head, kind of pressing or tightening, but not throbbing. Usually, it's usually mild or moderate intensity. And then it's not typically worsened by exertion, whereas migraine is kind of the opposite. It's more often on one side. Throbbing pain can be much more severe, although tension headaches can also be very severe. And then migraine does tend to get worse with exertion. So I typically ask patients, do your headaches get worse with moving around? You just tend to want to just sit still and not move much. And if they do feel comforted by kind of walking around, doing the normal routine during the day, that's much more suggestive of tension headache than migraine. Also, people shouldn't really have these migrainous features. So like really nausea, vomiting is kind of excludes you from pure tension type headache. You can still have nausea from other causes and then have tension headache, or you can have a mixed headache phenotype, we call it. So 2 different types of headache presentations, where you can also have migraine in addition to tension headaches. But true tension headaches shouldn't have nausea. And then usually you don't have light and sound sensitivity. The caveat with that is that sometimes, especially in the Southwest where we are at the University of Utah, and other places as well, you can have a lot of dry eye with or without having headaches. And dry eyes can contribute to light sensitivity also. So it's always important to think about, is that a problem also contributing to the light sensitivity? But again, with pure tension type headache, that shouldn't be part of the disorder. And then the last thing is that it shouldn't be better accounted for by another headache diagnosis. So that's where that comes in play, where I said, you want to make sure that your clinician will rule out other causes if they think it's possible. Not everybody with tension headache needs an MRI. In fact, probably most don't. But if there's anything unusual about this or other kind of red flag symptoms that have been talked about in other headache school talks, then that's always reason for kind of increasing the diagnostic workup. There's a couple studies that I wanted to just kind of really briefly go over, but one of these studies showed that people would describe these headaches as in a number of ways. So dull, non-pulsating, tight, sore, like kind of feeling like it's a band around your head or a cap on your head. Some people describe them as just like a heavy weight over their head and shoulders, just kind of a non-specific feeling. Um, and then these statistics kind of just support the last slide where we talked about it's on usually both sides, kind of pressing, mild to moderate, and then not worsened with physical activity. So pretty strong. I mean, those are all pretty higher percentages. So usually you have that, but it's not 100%. So you don't have to fully absolutely meet every criteria. And that's where the clinician can kind of help to split hairs a little bit better and kind of give you a more formal diagnosis. And then just interestingly, one study found that typically tension type headaches feel like they're coming from the outside going in, whereas migraine is sometimes pushing from the inside out. But we see tension headaches that do both. We see migraines that do both. So that's not really like a great discriminating factor, but just kind of an interesting rule of thumb. So treatments, we think about rescue and prevention treatments. And so rescue, also called acute treatments or abortive treatments, these work best for kind of less frequent headaches, so the episodic tension headaches. Same thing with migraines, less frequent migraines, rescue medicines tend to work better for. And then the prevention side, a preventative side, helps to reduce the frequency of attacks, hopefully also the severity, and how long they last. And these might also improve how effective the rescue medicines are, and hopefully reduce your disability, improve your function when you're having an attack. So rescue treatments. So there aren't any FDA. Should say there aren't any like prescription medicines that we use first line for tension type headaches. So typically these are over-the-counter medicines like ibuprofen or Advil, Motrin, naproxen, which is Aleve, diclofenac. These are usually not more than 2 to 3 times per week, or 10 to 15 times per month, but 10 per month is a good rule of thumb. Some of these, or some studies have shown that the NSAIDs are a little bit more effective than Tylenol or even aspirin. And I like especially the long-acting NSAID, naproxen, Aleve, just because it's a little bit less likely, I think, to cause rebound headaches, because it's a longer-acting, kind of longer time to offset. There's less of that peak and valley effect. The efficacy in general with rescue medicines, again, tends to decrease as the headaches increase. So the more headaches you're having, the less likely the rescue medicines are going to be effective. And then you also have to worry about, as these things escalate, that you're not overusing the rescue medicines, because you can develop this medication overuse headache, MOH in this slide, with a lot of different medicines, but including non-steroidal anti-inflammatories like these ibuprofen, naproxen, diclofenac, so NSAIDs, Tylenol also. So keeping those to no more than 15 days per month, 15 at the very most, but preferably less than that. Or when you're using them all in combination, that can actually make it more likely to have a medication overuse headache if you're alternating these medicines. In that case, you want to reduce it to no more than 10 days per month. Triptans have been looked at for tension type headaches: sumatriptan, rizatriptan, naratriptan. There's zolmitriptan, elatriptan, ferobatriptan. There's 7 of these total. Almo is the other one, elatriptan. But these have not been shown to be effective for pure tension type headache. If somebody has a mix of both migraine and tension type headache, they might be effective and they would be worth a try. But for pure tension, it's really not probably going to be effective. And they're also not indicated for people that have ever had a stroke or a heart attack or have Raynaud's disease, other things like that. These would be used off-label, but muscle relaxants like tizanidine or cyclobenzaprine, baclofen can also be used, but with again, it's not as strong of an evidence basis. So if it's a really bad headache and you just want to take care of it as soon as you can, you've been dealing with this headache for days and days, You can come into an urgent care, an emergency room, or if you are a patient of the University of Utah, you can come into our rescue clinic, either at either of our centers. And you can get, depending on the place that you go, and depending on the type of headache that you have, they might give you things like Toradol, which is an NSAID, dexamethasone, a steroid. If you do have nausea, or if you have like some component of migraine in your headaches, you can receive anti-nausea medicine like Zofran, Reglan, Compazine. Reglan and Compazine especially are a little bit sedating. And we often also combine them actually with Benadryl, which is also sedating, just to counteract some of the side effects. But going to sleep sometimes is a good kind of reset anyway for headaches, so that's not the worst thing. You just need to have a driver if you're going to get any of the sedating medicines at the University of Utah. I imagine most ERs and urgent cares would want to do the same thing too. At our rescue clinic, it's Monday through Friday, 8 a.m. until about 4 p.m. You do need to be an existing patient of of either the INC or the CNC neurology clinics and be plugged into the headache, someone that sees you for headaches. But you can come in on a walk-in basis. There's no need to call ahead necessarily, although it doesn't hurt to do so. If you need an IV infusion with fluids, because you can't keep liquid down if you had a migraine or something, less likely with a tension headache, then we can give you an IV as long as you come in before 2 p.m. So just a quick plug for that. Thought that might be helpful. Not everybody knows about that. So in terms of treatment, we think for prevention treatment rather, there's a number of different options. But the evidence overall is not as strong as it is for migraine. So there really, we don't have as many treatments as we for tension headache as we do for migraine, unfortunately. But among those that we do have, amitriptyline, which is an antidepressant, seems to have the strongest evidence. So even though it's an antidepressant, it's not being helpful just because of the antidepressant effect. Other medicines like Lexapro, for instance, I think citalopram, Celexa, have not been shown to benefit tension type headaches, whereas amitriptyline does. So amitriptyline is not the strongest antidepressant. We don't use it as much anymore, but it is effective in this case. It can also kind of independently help with muscle tenderness when they look at that more objectively at how likely you are to respond to certain pain thresholds. It also seems to inhibit central sensitization, which is that mechanism that's responsible for chronic tension headaches and also chronic migraines to a greater extent. But this seems to also improve that situation. There are other similar medicines that are used with a little bit lesser evidence even. So nortriptyline, desipramine, doxepin, there's some other ones. Those are all tricyclic antidepressants that are in the same category as amitriptyline. All of those have, at least nortriptyline and desipramine probably have fewer side effects, but may not be quite as potent. Doxepin can make you more sleepy, may help with chronic nausea, not as relevant for tension headache, but it also may not be quite as effective for tension, but it has a role. And then other antidepressants that are more specific for a tension headache are mirtazapine and venlafaxine. I like mirtazapine especially for insomnia and tension headaches. It can be effective for both of those conditions. And then venlafaxine is more often used for its antidepressant effect, anti-anxiety. It's a mood stabilizer. And can also be effective for migraines and vestibular migraines, especially. Did a talk a couple of years about that about that. And then some other medicines, also, lesser evidence overall, but these are worth a trial, if you're really struggling and you need something for prevention that your clinician might prescribe. So these are things like topiramate. That's one that we use a lot for migraine, a little less for tension headache because it has lesser evidence, but it can be beneficial. It can also help with sleep because it's a little sedating. I tend to have the higher dose at night. It's a twice-a-day medicine. Gabapentin is used for a number of different conditions, including neuropathy and even anxiety sometimes, insomnia. But it can be helpful for tension headaches also. That's another worth a shot at least. And then tizanidine I mentioned earlier. Really any of the muscle relaxants, but tizanidine has been studied the most, and it's been it has some mixed evidence though. So one study found that it was more effective than placebo. A larger study found that it wasn't as effective or no significant benefit beyond placebo. So, a little bit of a mixed bag, but anecdotally, we will sometimes use these either for rescue or prevention, depending on the circumstances. Usually for prevention, you'll use a muscle relaxant like every day, for instance, whereas for rescue, it's just as needed. And usually like the lowest dose we can get away with. Other things, so are procedures for headaches. So we'll sometimes try trigger points or occipital nerve blocks or just nerve blocks in general. These are using very small needles to inject a small amount of usually lidocaine or bupivacaine, something that is a local anesthetic, and then plus or minus a steroid, like dexamethasone, triamcinolone. Every center does this a little bit differently, and there's no like definite correct way to do it. The protocol has not been standardized. And so every center every even provider might do it slightly differently. But the goal is to kind of numb wherever we are, wherever the needle is, along that nerve distribution for a few hours, to the point where we can kind of shut down the incoming pain signals for long enough to hopefully kind of reset things and give you kind of longer lasting benefit for several weeks. And it does tend to be pretty effective for a lot of people, not for everybody, but it's worth a try, just in large part because it doesn't cause many side effects. Botox injections, interestingly, really aren't effective, and they're not covered by insurance. They're not, used for tension type headaches, really only for chronic headaches, which is, kind of a little bit of a mystery, because tension headaches we know are related to muscle tightness in these areas, and Botox kind of helps to paralyze those muscles. So it's not really clear why this doesn't work, but surely more studies are needed. But so far, the small number of studies that have been done have not been shown, haven't demonstrated actual benefit or significant benefit, at least. All right. And then, other things that can be helpful are lifestyle modifications. So kind of maintaining a headache diary can be helpful to kind of identify some of these triggers. So dental disease. So if you notice like you tend to have headaches after eating like a sugary meal and your teeth hurt, that could be related to having cavities. If you have a lot of jaw pain related to your tension headaches, always a good idea to see a dentist to rule out TMJ or other problems. Some of these headaches can be associated with hormonal changes, migraines especially, and to a lesser extent tension headaches. But it's important in women to kind of track your cycle as far as your periods and your ovulation goes. If your headaches are strongly tied to that, then that could be a good clue that we need to treat those times a little bit more carefully. Sinus disease. So often sinus headaches are confused as migraine headaches. They're really migraine masquerading as kind of sinus headaches, like if it's just congestion here. So but true sinus disease, so like kind of runny nose, congestion, postnasal drip, sore throat, a lot of allergy symptoms, sneezing, that type of thing. If that corresponds to when you get your tension headaches, that's important to know, and that might warrant additional testing. If you're a shift worker, your sleep is all messed up because of that, that can be a problem. Postural problems with work. I mean, a lot of us are in front of a computer all day, and that can contribute to to dry eye, light sensitivity in migraine, for instance. But just the kind of ergonomics of your working condition, the posture, that can all contribute, especially to tension type headaches in that forward head position. Not eating healthy meals, not getting great sleep or consistent sleep can also be triggers, and these can be identified using a headache diary if you're marking those things down. Certainly stress and anxiety and depression tend to come with the territory with any sort of chronic pain condition. We don't think those are probably causing things, but definitely contributing to them. So we don't call this like a psychogenic headache anymore, because we know that's not the cause, but it can definitely be strongly linked. And without treating both of these conditions together, we're not going to get as far. And then sometimes, again, overusing medicines, even over-the-counter medicines, can contribute to headaches. And so it's always important to not exceed like the recommended limit of those medicines, um, because they can chronify your existing headache disorder, but also lead to these individual rebound headaches. Um, Sometimes physical therapy is a really good option. In really most cases, it can be helpful if you have a lot of neck and shoulder tenderness, in addition to the headaches. So a lot of tension type headaches, that just comes with it. And there's a number of different modalities they can use, kind of along the lines of, mobilizing your neck and your shoulders, just kind of increasing the range of motion, helping with posture, and then strengthening your muscles in general, just to kind of compensate for the changes that you've kind of developed over time, and to help with these headaches, hopefully too. And then, some other things that are helpful. So some psychological strategies, so biofeedback, which uses an instrument that monitors a bodily response, like muscle tension or skin temperature, as the person tries to modify that response and help with their headaches. Deep breathing can be used, progressive muscle relaxation, guided imagery, mindfulness meditation. We have a couple of talks on some of these topics kind of earlier in the catalog of the Headache School, which you can review also. Cognitive behavioral therapy is another modality that's used a lot for different types of pain, but can be helpful for tension headaches. CBT, or cognitive behavioral therapy, it teaches patients to identify thoughts and beliefs that generate stress and aggravate headaches. And this has been shown to be very effective for it, either by itself or in addition to something like amitriptyline, that's the TCAs, or tricyclic antidepressants. So a combination with CBT plus something like amitriptyline is better than using either one alone. And then acceptance commitment therapy is a little bit newer, at least, or I've started hearing about it more recently. And this is a type of mindfulness-based psychotherapy that emphasizes acceptance and modifying expectations such that it becomes easier to limit the control that these headaches exert on your life. And this, I believe most of the data from this comes from other pain disorders, but it has been looked at attention type headaches, and it may also decrease the headache frequency and medication use in general. And it's a pretty benign treatment. It's not going to cause side effects. It can just be time consuming, like anything else might be. So definitely worth a consideration. And there are actually talks on both of these topics, CBT and ACT, from Taylor Burhouse, our social worker, earlier on in the YouTube that you'll find. Just briefly, a couple of these things I just thought worth mentioning. So this Renpho eye massager, this has not been evaluated by the FDA, and there are a number of companies that make them. I don't stand by Renpho necessarily. I don't know much about the company itself, but this type of device can be helpful in patients who have a lot of pressure behind their eyes and in their forehead. I don't recommend it for anybody that has glaucoma or pre-glaucoma, because it does push on your eyes, and it also causes a little bit of heat. So if you have a lot of dry eye, I probably wouldn't recommend this either. But for people that you just find that pushing on your eyeballs is helpful, this is a great option. There are a number of different models, and you can take a look at the reviews on Amazon or elsewhere. This other thing is shiatsu massager. I really like also. This is a corded device usually. You put it on your shoulders, and then these little red knobby things kind of rotate and massage your shoulders. You put your arms through these straps so you can kind of adjust like how much tension is on your shoulders. And that's a great way just to kind of sit there and veg out and have a nice massage at the same time. This is called an ice cap. There's a number of different brands that make things like this. This one is nice because it can go in the freezer or the microwave, for hot or cold. And it can be great just to kind of sit there also if your headaches respond to heat. I'd probably just try like a regular ice pack or heating pad first before spending the money on something like this. But if that does work, that's great, and it's an easy thing to use. And then lastly, these devices, like a Theracane, back knobber. There's a bunch of brands there too, and these are just nice to kind of hook into your shoulders and the muscles in between your shoulder blades to kind of work out these muscle knots or trigger points that you can get. So you can use like a heating pad first, or like a rice, like a moist heat from like a rice sack, and then push with these things on your muscles for like 60 to 90 seconds. Just make small little circles. You don't want to push so hard so as to bruise, but that can work out some of these little knots that you can get, that a lot of us get, which is sitting in front of the computer or living your normal life. And I don't stand by any of these particular companies, but I mean, they're all great. I've anecdotally had great success with a lot of these with a lot of my patients. So definitely worth the purchase if you're curious. And I think that's it. This is a little plug for our Miles for Migraine event that we're holding this year. This is the third annual event. It's a fundraising event for our headache fellowship. So all of the funds that get that come to the Headache Champions team, or that get donated to the Headache Fellowship directly, they all come into us, and they help to fund our next rising doctor who's going to be a headache specialist, hopefully someday soon. So this is on August 5th. It's coming up. It's on a Saturday. It's at 8:30. It's at Memory Grove Park, which is downtown Salt Lake City. Parking will be a little bit limited, so just make sure to try to find parking early. To register, you can either follow this QR code or go to Google or whatever search engine and type in Miles for Migraine Salt Lake City. You can register for free, which is new this year. All you need to do is create this race roster account that you don't get a lot of extra emails. I haven't. And then you join this University of Utah Headache Champions team if you're so inclined. You can join any team, but it helps us if you join our team. And then you can also donate to our team directly, and that does help us, of course, but that's entirely optional. And that's it. Thank you, everyone, for your attention, and hope you have a good day.